Welcome back to the deep dive. Today, we're really getting into it with health assessment. Taking that core knowledge, the stuff often called NUR216, we're looking at how to turn that theory into, well, clinical instinct.
Exactly.
Because this isn't just ticking boxes, right? It's about quickly getting a handle on the whole person in front of you.
That's the mission today. We want to show you how those assessment frameworks, which can seem a bit dry sometimes, are actually the blueprint for clinical judgment. We're unpacking how you build that baseline health picture, and maybe more importantly, how you take all these separate pieces of information, physical stuff, behavior, social factors, cultural beliefs, and turn them into something actionable, something that saves lives.
Yeah, and that scope is just huge, isn't it? The sources really hammer home that a real health assessment has to be holistic. It's way beyond just the main complaint. It covers physical status, mental health, spirituality, their social situation, even, economic and political things that affect their care. That's a lot.
Right. And to even begin processing all that information, you start with the clinical judgment process. Step one is recognizing cues. That's when you're just gathering everything through the interview, the physical exam, just simple observation. But before you analyze anything, you absolutely have to nail the difference between the two basic types of data.
Okay, yeah, let's dig into that. Subjective versus objective data. It sounds simple. Subjective is what the client tells you, their symptoms. Objective is what you observe and measure, the signs. But the source material is really specific. Subjective data must be documented as a direct quote. Why that's so strict?
Good question. It's because subjective data, it's essentially the client's testimony about their experience, their story. If you start paraphrasing or interpreting it, you're immediately putting your own spin, your own bias onto it. So if the patient says, "My back hurts a lot," you write exactly that, verbatim. If you write, "Client reports severe back pain," well, you've just jumped from quoting them to making an interpretation. It might seem subtle, but it's a big difference. The goal is pure accuracy and documentation. "I feel nauseated," period.
Right, capturing their exact words.
Yeah.
And then objective data needs to be just the facts, ma'am.
Pretty much. What you can see, hear, smell, feel, respiratory rate is 22 per minute, or maybe the client grimaced when I palpated her right lower quadrant. It has to be observable, demonstrable. No opinions allowed.
I can see how that line might get a little fuzzy, though. Like, if a patient is pacing and wringing their hands, isn't writing "client seems anxious" kind of subjective?
That's a super common trap. Seems anxious is absolutely an interpretation, an opinion. You have to translate what you see into objective signs. So instead, you document something like, "Client observed fidgeting, tapping foot rapidly, speaking quickly."
Okay.
See? That's observable data. It might suggest anxiety, but you're documenting the behavior, not the conclusion.
Okay, that makes sense. Describe, don't label. So once we've gathered and documented those cues properly, the clinical judgment process says we need to prioritize, moving from gathering to analyzing quickly.
Exactly. Step two, prioritizing hypotheses. You're essentially triaging the information based on how urgent it is. Primary issues are the immediate life threats, think ABCs. Airway, breathing, circulation. Always first.
Always.
Secondary problems need quick attention, things like managing acute pain. Tertiary issues are important but can wait a bit, like planning discharge teaching. The hierarchy is key.
Can you give us a quick example of how that plays out?
Sure. Let's say you have a post-op patient. They're rating their incisional pain at an 8 out of 10. That's significant, right? A secondary priority.
Definitely needs attention.
But then suddenly they start breathing really shallowly, making kind of a gurgling sound, can't speak clearly. That's an airway issue. Primary. The need to sort out their breathing, maybe get oxygen on them, secure that airway that immediately overrides the pain management. That's the process in action.
Got it. ABCs trump everything. And then step 3 is setting goals.
Right. And these aren't just any goals. They have to be SMART goals. Specific, measurable, achievable, relevant, and time-bound. This makes sure the plan is really clear, everyone's on the same page, the team, and ideally, the patient too.
Okay, so this whole structured process, it really depends entirely on good communication, doesn't it? If you can't build trust, you won't get accurate information to begin with.
Absolutely critical.
The sources talk about needing presence, respect, caring, understanding, and list traits like empathy, respect, using silence, open-ended questions, and even touch carefully.
Those positive traits are vital, yes. But honestly, for clinical judgment, knowing the communication barriers, what not to do, is maybe even more crucial. Top of the list. Avoid giving your personal opinions or advice. Saying something like, "Oh, when I had my gallbladder out, it was easy," just dismisses their unique situation and centers yourself.
right? Shifts the focus. And that connects to false reassurance too, doesn't it? We want to be positive, but telling someone, don't worry, you'll feel better tomorrow. Why is that a mistake?
Because you simply can't promise that. And if they don't feel better, you've broken that trust you were trying to build.
Hmm.
It comes across as a cliche, like you're brushing off how they feel right now. Honesty and presence are much more therapeutic.
And the classic why question. Why is asking why specifically often a problem?
It tends to sound accusatory, It can make the patient feel defensive, like they need to justify themselves. Think about, why did you wait so long to come in, versus something like, what made it difficult to get here sooner?
Ah, yeah, much less judgmental.
Exactly. The second way invites them to share their circumstances. And another thing, don't fire off questions like a machine gun. Ask one question at a time. Let them answer fully. Clarity is key.
Okay, so avoid advice, false reassurance, why questions, and rapid-fire questioning. Once we navigate those pitfalls and build some trust, we get to the actual health history. The sources mention 5 main parts.
Yes, the health history is foundational. First, the reason for seeking care. Simply, what brings you in today? Use their own words. Second, biographical data: name, date of birth, occupation, allergies, that kind of thing. Third is past history. Think childhood illnesses, adult conditions, surgeries, injuries, the timeline of their health before this current issue. Fourth, family history. We're looking for patterns here, things like diabetes, heart disease, certain cancers, stroke, and close relatives.
Right, the genetic predisposition. And the 5th piece is the history of present illness, the HPI. This seems like where the real detective work begins for the current problem.
Absolutely. The HPI focuses only on the illness or injury that brought them through the door today. You need details. When did it start? Where is it? How long does it last? What's the character of the symptom? Sharp, dull, aching? What makes it better or worse? It's basically applying that PQRST pain assessment framework, which we'll talk more about later, to the story of their current problem. It gives you the narrative.
Okay, now thinking back to that broad, holistic assessment idea that really forces us to consider special needs and cultural factors, especially during the interview, right?
Yes, absolutely. And the key principle here is you must assess the impairment first. If someone has a visual impairment or hearing loss or cognitive issues, you need to understand the extent of that limitation before you can adapt your approach effectively.
Makes sense.
So, for example, with a patient who has aphasia after a stroke, they might understand you but can't speak back easily. Shouting won't help. Maybe you use a whiteboard for them to write answers or picture cards. You adapt.
And cultural considerations can really change how you even do a basic exam, can't they?
Profoundly. Different cultures have very different norms around things like eye contact. Is it respectful or aggressive? Physical touch. Where is it? Okay, who can touch whom? Personal space, modesty.
Opposite sex providers, too, sometimes.
Exactly. All of these can impact rapport and how much accurate information you actually get. For instance, if a patient's beliefs require significant modesty, you can't just ask them to fully disrobe. You might need to listen to their back first, then carefully drape and listen to the front in sections, always maintaining their privacy and dignity. That's putting anti-oppressive practice right into your assessment technique.